Ready? 3, 2, 1.
Well, good afternoon, everyone, from the world headquarters of the Blanchard Valley Health System here in Findlay, Ohio. Thankfully for most of you, I'm off camera this time. I'm Scott Malaney here again. This is the 5th of these we've done. Thank you for tuning in. The two gentlemen you can see, Karim Baroudi. Karim is a visitor this time. He is the Hancock County City of Findlay Health Department Commissioner. We're delighted that he would agree to join us tonight. And then the familiar figure of Dr. Bill Coase. So I'll be reading some of the questions, may comment on a couple of the answers, but mostly we wanted to allow you to see and hear from the experts. So we're going to get going here, and as always, thank you for joining us again. If you have questions or comments, feel free to type them in. We will be fielding those as we go along, and hopefully it can be an hour of good conversation, good learning back and forth. So our first question comes from Drew in Bowling Green. By the way, Drew, thank you for your question. With the governor's recent travel order, what is BVHS doing when associates, that's our language for employees, takes trips? Do they have to quarantine before returning to work? Dr. Coase?
So this is something that we have talked about. First, the governor's order was talking about anyone that's visited a hot state, and that's defined by about 15% positivity. And there were listed, when he originally gave his promulgation, about 9 states that if you came back from, that you should be really careful first if you go there. But as you came back, that you ought to think about self-quarantining, especially if you hadn't been able to social distance or had been in places where that there was a high level of COVID virus. So from a standpoint of answering the question now from BVHS, we did not make that mandatory. Neither did the governor. We think individuals should do exactly as I talked about, social distancing, et cetera. But when you come back, you can still report to work. We're asking that you make sure that you don't have any symptoms, that there's not anything occurring. If you're in a certain, and depends on the department, that you may need to have more protection as far as the mask you use. What I would say is I would refer you to the memo that we sent out. And if there's any questions, talk to your department manager or check with Human Resources.
Thanks, Bill. Thank you for that question again. Chelsea from Findlay asks, what is BVHS going to do to shorten the time it takes to receive C19 test results? I heard results are taking more than 7 days. Before I hand this off to, I think Karim and Bill will both comment, but the high level comment is this is a national problem. There is simply more demand than there is ability to meet the demand. So it's a very timely question. Maybe Karim, from the standpoint of the health department, how would you like to comment on that question?
Well, Scott and Dr. Coase, first, thank you for inviting me. This is going to show our community here and the people we serve how close of a partnership we have with the health system as we are responding to the pandemic. From a testing standpoint, I think this is not unique to Blanchard Valley or unique to Findlay or Hancock County per se. We've seen the last couple of weeks after the testing eased up a little bit a few weeks back, that there's a backlog of testing results coming back. Again, it's not only here. I hear it all over the state on my calls and on my meetings. You hear it nationally, on the news cycle and with calls with the task force and everything. They're working on that backlog. I think it got to do with labs and reagents coming in and out of the system and trying to make it better. I hope this will ease the next couple of weeks, Dr. Coase. I don't know if you heard something else.
I would reemphasize what Karim said. One of the problems, at least what we understood, we found out about a week ago, we weren't going to have as many tests. That tests were being, I'll use the word diverted to those states that had hotspots. The bus stop, I heard that today, the Florida, the different places where there was a lot higher level, and therefore they needed those reagents. So what we found out was we were not going to be able to get and use the capacity that we've had. This morning, one of our vice presidents said, we've done 60% of the testing for COVID in the last 3 weeks. We've gone from doing 200 tests, say, a week. We did over 1,000 last week. And so there's much bigger demand at the same time when we have limited resources. And I think that theme will come back through what we talk about today. We're trying to prioritize who do we need to be testing. In general, everybody like to have a test. It sounds like every football team wants to have tests, and whether that's where you're talking about fellows that are in 3rd grade or whether they're playing professionally, that everyone would like or needs to have a test. And so we're trying to, again, prioritize. Businesses want individuals to have testing before they go back. Specifically related to the hospital, we need to know an individual coming in with respiratory problems being admitted, whether they have COVID, because we have a different sort of treatment. Our protocol would put them in a negative pressure room. It also gives us an idea of what to expect as far as what problems may be. And then we've got the other, not another part of that, but another segment where we need these testing is for patient safety. We'd like to know if you're going to have surgery, especially elective, that do you have a positive test that would indicate, even if you don't have symptoms, that there may be a higher risk of having surgery. So we're trying to figure out how to do that. And part of the problem of that is we can do the test, but we can't get it back as quickly. So agree with what Karim said, and we're trying to work through all of those things. We've been able to keep up with our testing so far. I don't think we've had any patient safety issues. We haven't seen any, but it is a national problem.
Just to fill in a little bit, to give you a very specific example, Blanchard Valley in our lab has the ability to do 12 tests at a time. They're little cartridges, and it takes roughly an hour to do a test. So you can do the math. We could do 100 tests a day, theoretically. We only get 60 cartridges a week from our supplier. And it's a huge issue. That's part of the reason why this is taking so long. And as more people want tests, another place we send to, for instance, is Mayo Clinic. Early on, their return time to us was pretty quick, but they're just inundated. And we actually called them yesterday and asked if they could help us more. And they said, no, we can't. We can't do what we're supposed to do now. So the demand is, as I said, outstripping the capability. So thanks for that question. Here's another one that's right along the same line. Debbie from Finley asks, what's the average time for test results to come back? It seems the timelines are different when comparing why you were getting the test in the first place.
So from a standpoint, remember there's different kinds of tests. I think what we're basically talking about with this is, do you have an active disease? That's an antigen test. Our goal is to get those back within 48 to 72 hours, especially for electives, let's say elective surgery, where we are sending those out. If we're able to and have the ability, the number that Scott talked about, we may be able to turn around those in a couple of hours if somebody's in the emergency room. We are saving those few that we have to be able to make the most immediate decision that we can. So it depends. But what we are seeing is some of these that we've sent out that have been routine, someone we're checking, that it's been up to, it can be up to as far, not just here, but across the United States, 7 days or more. I don't know what you're seeing, Karim.
Sure. Well, I'm kind of seeing the same thing, but I want to emphasize that, fast return on test results, it's really important for public health. Because as what we use the test for is to try to contain. If we have somebody that's infectious, we want to make sure they've been contacted with public health so they can quarantine and isolate per guidelines. So if the test has taken 7 days, Dr. Coase, the contact tracing part of what we do in public health and, as we respond will become a moot point, because we don't want that person waiting and spreading the virus while, they might come back positive in a week. So it's important that we increase the capacity up to a point where we get it quick enough. 24 hours, 48 hours is still acceptable. I think we're working closely with the hospital and lobbying the state to get us some help here. We even reach out to the region to see if we can get some help. We want to increase capacity, want to increase testing, but return on those tests fast enough is important as well.
Thank you. You made a great point there. Next question is Holly from Finley. Thanks, Holly. I think Holly may have a couple questions here. A friend shared that her pre-surgical COVID screening was done through the mouth to the back of the throat. I thought COVID screenings were taken through the nasal passage to the back of the throat. Can you please explain the difference as to why surgical screenings are taken through the mouth? Bill?
This specific question asked about screening for pre-surgical. I'm going to answer it in general, and Karim, if you want to add anything more the way you look at this. So what we want to do when we're doing any kind of testing is to get to where the most likely place that we're going to find, in this case, a virus. Initially, it was felt in nasopharyngeal, and that was going through the nose. And when we started, we had a wire. It was not the most pleasant thing to have done. The FDA changed not so much their opinion, but after we did a lot of testing and it was scientifically looked at, randomized, it was felt that in general that you could go to the back of the throat, which is much easier. I just went through this about 3 or 4 weeks ago, and I don't want to say it's safer, but it certainly is not as irritating as going through your nose. The data that's coming out for asymptomatic screening, it didn't make any difference whether you use the swab either through the nose or the back of the throat. Now, sometimes though, when we're looking to make a diagnosis, we may want to use different testing. Sometimes to be able to tell what something's in the lung, you may even have to put a bronchoscope or a tube down where you can get closer because you want to get the best specimen, as I said. So you may want to do it nasally. You may also do it in the throat. And now there are tests that are being used that can look at sputum. So we've evolved the testing, but basically either place that you have it done for pre-surgical screening, we should get the same results. We feel comfortable with that. The surgeons feel comfortable with it. I don't know, as far as your screening,
Perfect.
Make any difference for what you're looking for?
Not at all. I mean, because it was a new virus, we didn't know exactly what's the viral load is going to be on the sample when we collect that. And that's why the first recommendations came that you need to go through the nose and as deep as you can. This is very uncomfortable. I agree with that. So later on, they found out, the same viral load to give you an accurate test can be collected from the throat, which is a lot easier, a lot more.
Yeah, and I really appreciated not having that thing stuck down my nose and then trying to drive off.
I thought that was done to test your gag reflex.
Well, supposedly, if you did it right, I was reading about this, you should start crying. Well, I was crying before I even had to think with it.
And just to the same point, if you allow me, just have a minute here. Public health has heard a lot, and I'm sure the hospital did as well, about self-administered tests that you get by the mail, and you administer the test yourself. And we talked about being uncomfortable in kind of getting the swab as far as we can get, so we can get a good sample. A lot of those, we're seeing some false negatives coming back with those, because if I'm doing the test myself, the minute I start feeling uncomfortable, I won't get a good sample. So please keep that in mind. If you are testing through one of the commercial outlets here to self-administer the test, you want to make sure it does feel uncomfortable and you collect a good sample so we can get a good test out.
Great point. Thank you. Yep. Next question from Holly. Can you please comment on where we stand with personal protective equipment within the health system as well as across the country?
We feel at Blanchard Valley that we're in good shape right now. We have at least 4 weeks. We have been stockpiling. We have been looking at our vendors and our suppliers to make sure that we have all types of protective devices. Masks have been the biggest thing, but also in addition to that, gowns and other paraphernalia, including masks, that we feel pretty comfortable unless we would get a tremendous surge. But we have contacted other places. The state of Ohio has worked as well as regionally in northwestern Ohio that we think we can share. Ventilators were one thing we talked about on our first broadcast. I think that there was a concern. We are not putting as many people on ventilators. Ventilators are readily available, and that doesn't seem to be a problem. I think across the United States we feel fairly comfortable, but what I've heard, I don't know whether you've heard in Ohio or other, there are places that have been somewhat short, but we've been able to keep up so far.
Yes, and that's accurate, countywide as well. From our operations and the response, we do have our EMA director on our briefings, twice a day. We make sure that we have, enough stockpiles. We're requesting enough PPEs from the state and from the federal government as well. I think in the beginning it was very sketchy, and we were all scrambling as the pandemic hit, where to get PPEs, where to get the N95s. The need was priority to first responders and healthcare workers who are on the front line. So we did, we satisfied that as much as possible. Now we are stockpiling, and we've heard a lot, and I think we want to be prepared for another surge on the hope that it will never happen. But I think we're prepared here for the fall, countywide as well, to have the proper PPE for first responders, healthcare workers, as well as people on the front line.
Great, thank you. Mallory from Ottawa asks, if I feel I'm exhibiting symptoms, how do I go about getting a test? Dr. Kos?
Well, the testing from the standpoint of the system and also across the community would be to see your primary care provider to have an evaluation, whether it's by telehealth or by seeing them or by talking to them. You do need a physician order. We are also doing testing through Physicians Plus. We're not doing the drive-through that we had originally started when this began. But again, primary care physician would be who to talk to. And again, I don't know if there's anything different that you're advising.
I think that's from the hospital standpoint, I think, and that's still the reason why we're, we want to go through this. And what I can say from public health standpoint, we do not have mass testing yet. We're lobbying hard with the state to do one of those pop-up testing where the National Guard will come in and offer tests to people who are asymptomatic. They don't need a doctor's note. And that will be mostly for surveillance. But I think with the limited supply that Scott and Dr. Kos talked about, and countywide, we want to make sure priorities are for the people who are sick, who have symptoms, who are going through the hospital system.
Good. Let me take a quick time out here. Jen, got anything you want to add to the questions at this point, or comments?
Yeah. There are a few questions. One, Nikki from Finley asks, what about herd immunity? Would we all just get it? Would it work?
So from a standpoint, now this is a public health question. So
now you might want to explain what herd immunity is.
That's why I'm going to give him the second shot at it. So basically the idea is that when you talk about, whether you're talking about vaccinations, whether you're talking about individuals getting sick, that you need to get to a critical number, whatever that is, that the entire population has been infected and has developed antibodies, which means that they theoretically should not get this again. And the epidemiological models that public health uses usually say if we can get to 50 to 70% of the population that have an antibody, the disease will not be nearly as, well, first 50 to 70% of people have already had it, and it's going to start to die off. Now, that's not complete, but the idea then behind herd immunity would be you take the population of the United States, I think it's 330 million or something like that, divide that by 2, 160 million people are going to have to get this. We've had 4 million people have COVID. So yeah, that is one way of doing it. Didn't work too well for Sweden, Italy, China, or anybody else that just said, okay, let's go out and get everybody sick, and then we'll have enough of herd immunity. And that's really not the question that was being asked. We do need herd immunity. Our goal when this all started, bending the curve, was not we were going to eliminate it, we were going to flatten it so that we could get to a vaccination. I mean, that's the end point, the goal Dr. Fauci talks about and everyone else is, and those that understand that is where we need to be. But herd immunity is important. That's why not everybody gets flu. That's why we give flu shots. That's why we give measles shots. That's why we give all of those things. So there's enough out there that the 70% that are with antibodies are protecting the other people that don't, because there isn't any place for the virus to go.
Anything to add, Karim?
Perfect explanation. Herd immunity is very important public health concept where, again, the majority of us will be immune to a disease, so we can protect the people who cannot be vaccinated.
Right.
That's, immunization. We use that same concept there. With this virus being new, and like Dr. Kos alluded to, we don't know exactly how much of a protection we're going to get, especially long term.
Right.
Scott talked before about being having antibody for a short term that's protecting us. So like the common cold, we don't have herd immunity for the common cold, and I think the scary thing with this virus is it gonna behave the same way, where we have to take boost shots once we have a vaccine. How often? How long would a shot will protect us? So herd immunity is very important, but to let it go naturally, like Dr. Kos explained, it didn't work in other countries, and it was going to do a lot of harm if we let it work here. All we're doing is buying a little time here to get pharmaceutical intervention to work on that virus.
Jen, anything else?
Yes, Casey from Finley. There are so many rumors in the community about COVID cases and/or numbers being inflated and wrong. How can we help everyone understand that those are just rumors and that the results and number of cases are being documented correctly?
There's a lot in that question, but Karim, why don't you take a crack at that one?
I can start on it, and you guys can back me up too. A couple things, and we have a system that's tied up to the CDC system. So each and every case we report on, whether to the state or to the federal government, has a unique number attached to it. So there is no way we can inflate the number of people, because each and every case, and if we are reporting on 294 cases as of this evening, those are unique cases. There's names attached to those. There's identifiers as date of birth, where they live. Our nurses are getting in contact with them. So it will be to rig the numbers. It will take a lot of people and a lot of effort to go into that and make up names and numbers and addresses and identifiers that we sent to the federal government. I think it will be a really big conspiracy that it will be almost impossible to do that. So the numbers we're reporting on are as accurate as it can be, because sometimes we don't get all the information up front, but usually the reports, by the end of the week or by the end of a couple of days cycle, they will be as accurate as possible, and they will be shipped to CDC for them to add them to the whole numbers coming from the country.
If you'll bear with me, another part of that question, I think, and I've been asked this multiple times this week alone, is it true you hospitals are making a bunch of money because you're just coding everybody as COVID and you're getting extra money? Let me explain that real quickly. The answer is no. But here's what happened. When the hotspots originally occurred and all the deaths occurred, autopsies were not done on everyone that passed away. And at that time, the government did make a decision that said, if the death is coded as COVID related and they're a Medicare patient, so that's someone over 65, you get a flat amount that you get for that disease entity. Medicare, by the way, pays you a flat amount depending on what the sickness is, and then we'll put 20% in addition. So do I think it's possible some people that passed away got coded as COVID and we don't know for sure that they were? Yeah, I think that's possible, but it would only be in the hotspot cities. That would have been Seattle, San Francisco, Chicago, Detroit, at that time, New York City, a little bit Atlanta, those places. That is not happening now. So this idea that hospitals have cheated the system or fudged the system and made a ton of money, absolutely not true. So I'm glad that question got asked, because as I said, I've been asked that 3 times this week. And Casey, thank you for the question. I'm going to go back to the questions I had before. This is a good one for you, Karim. Gary from Arlington asks, if I am confirmed positive C-19, how does contact tracing work?
All right, and that's very important for all of us to understand how contact tracing works. We heard the concept on TV, and we heard people and the pundits kind of discussing this. But from public health standpoint, the first point would be to get the test. If your test comes back positive, it's by law that all the providers, all the hospitals, all the labs report positive to the local public health. Once we get a report of a positive, right away we'll start collecting information, vitals, date of birth and age and all the demographics. Part of that, we call it demo sheet. The demo sheet will have a phone number, a good phone number for you, that at the point of care where they did that test for you, they ask for a good phone number to reach you. We'll get it right away. We'll get on the phone. We'll assign that case to one of our contact tracers. Now we are using our public health nurses mostly to do the contact tracing, because a lot of the people we're talking to on the phone, they might have medical questions, and they will help them better that way. So they will get in touch with you and discuss a little bit where you might have been exposed, and the symptoms. They take a lot of the incubation periods and how we determine isolation and quarantine periods as well get to do with when you were exposed. And according to criteria from the CDC and Ohio Department of Health, we determine when you got the virus and when you started exhibiting symptoms, and we go to the calendar and we count the days that you need to isolate. The public health nurse on the phone will give you guidance on how to take care of yourself and what to do in case your symptoms got worse with time. They will ask you to take your temperature. They will provide you a log. They provide you all the support you need, and they will ask you to stay at home. This is the most important part of the contact tracing, because we're doing that contact trace to contain any potential spread. And again, I talked a little before about testing coming back quick. The quicker we can know and you can know if you test positive, the better we are at the end of it, because you'll know that you're infectious, you know what to do, how to isolate, what you can and cannot do as far as contacts with other people until you're out of the woods and everything is okay. Then you'll get a call again and say you're released from your quarantine or isolation, and you'll be good to go.
That's a great answer, Karim. Thank you.
Are we locally, do we have enough caseworker? I know that was one of the big concerns when this all started. Do we have enough people trained that can go out and be able to do this?
Yeah, and then in the beginning, Dr. Kos, our numbers were so low, and it's not a secret now, and you've heard a lot, me and other health professionals kind of talking about the surge we've been getting the last couple of weeks. We were a little bit, under stress a couple of weeks ago when we had that surge, and we had to reassign people within the health department to help with contact tracing. We've got a lot of citizens, a lot of retired nurses, the University of Findlay, pharmacy students and nursing students. They all wanted to help with contact tracing. And I think we're still working through some of the details on how we can give them access to the secure system that tied up to ODH and CDC, and how we can have that confidential information, from the hand of the public, while they wanted to help and they want to volunteer. So we want to get them through the training. We want to prepare the army, like you said, a little army of contact tracers to just activate when needed.
Okay.
But as we're keeping up,
Getting the community coming together, volunteering.
absolutely.
And helping. Yep.
Guys, we got a lot of questions here. So
Sure.
And I'm being the timekeeper. We're a little past a half an hour.
All right.
It really is neat that so many of you took time to send in questions. Thank you. Caleb from Arcadia asked a great question. And Bill, I'm going to ask you to take a shot at this one. I have a scheduled vacation in August. If we choose to go, what steps should we take to protect ourselves while traveling?
Well, one of the first things is where are you going to go? And so make a decision. I wouldn't go to a hot spot, or if you want to be at a secluded place where you could be, so that you can follow the usual rules, the same thing that you would be doing here. So you want to social distance, you want to wear a mask, you want to make sure that you have respiratory etiquette. So if you're coughing or you're sneezing, that no one else is going to get that. Now, if it's just your family on a beach, that would make a difference versus if you're going to be in a downtown hotel somewhere. The question I get asked too is, what should I do while I'm traveling? I think that most likely, from what I can tell, hotels and motels have done a really good job of trying to decontaminate. So I wouldn't want to tell people not to stop. A lot of individuals feel pretty comfortable by just driving through. I think going through a fast food where you can pull up, that you're not going in a restaurant, is probably safer than what you're going to do. But I don't know that it's an awful lot different than the things we're asking people to do if they stay at home, the social distancing, et cetera. You add anything to that?
I think that's a perfect answer. You want to be careful, and that's what I tell everybody when I get that question. Now is a good time to be germaphobe. Make sure a lot of hand hygiene, wash your hands, don't touch your face. Be aware of your surroundings as you stop at rest stops and everything else. It's all to protect you, but the same rules applies everywhere.
Yeah, the location's not as important,
Yep.
whether it's hot or cold. What we're seeing where the problems are the parties or the getting together. And if you just think about it, connecting the dots, if you're with a group of 8 and you have 16, well, you don't just double your exposure, it's quadrupled. And that is probably as big a thing. And then we're still worried about the nursing homes, the congregate living and those things. But trying to limit the number of people you see without social distancing seems to be the problem, especially if it's inside where there's limited ventilation.
Yeah, thank you. And I was just my editorial comment is outdoor safer than indoor.
For sure.
Absolutely.
Karen from Finley is asking, when C-19 came to the U.S., the CDC did not recommend face masks for those who aren't sick. Why is there a push for us to wear them now?
Well, I can start on this.
Yeah.
Again, we go back, we didn't know too much about this. When we had our first talk and when the original ideas came out, we were trying to protect healthcare workers. We did not have enough PPE. And so we had to have a front line. That would have been us here. It would have been public health. And so there weren't enough masks. I don't know that it was specifically CDC looked at that. They've come back and they've said that, and I think it was probably true, that if we would have had an unlimited supply of masks, I think there would have been a recommendation early on. That's what South Korea had done and a lot of other places. That's not our culture, et cetera. But with that being said, we were trying to flatten the curve, and we wanted to make sure that we had enough here that, and not just us, primary care, anybody who was on frontline, the EMS, that they were going to be protected so that they didn't spread it. And so we still had people to be taken care of. And so as it evolved, as our community made a lot of masks, and as we were able to look at the scientific evidence, we didn't need N95s, that there was at least maybe not the best, but it was better than not doing anything by far. That as we were able to get more masks, it just made common sense that let's have everybody wear a mask, because you're going to protect yourself somewhat. But more importantly, if you are an asymptomatic carrier, meaning that you have COVID and you can give it to someone, that is going to protect someone else. So what we're really trying to do, I'd say, it was almost a moral obligation to be taking care of each other by wearing a mask. And it evolved, as I said. Now, again, if
Perfect answer. I don't want to add much. It's more than a moral obligation. It's a civic duty. That's the way I look at it. Things are evolving. This was a new virus 6 months ago, and now we know a lot more about it, and there's a lot more we don't know. So as science evolves, I think we should keep an open mind and say, okay, you know what, this is going to protect me a little bit and protect the others a lot. It's a simple jest, act of kindness. We should do it.
Thank you. Next question is from Kimberly from Finley. And Karim, I'm going to field this one to you. I think this is probably on the minds of an awful lot of people.
Yes.
How can we consider opening schools when COVID-19 cases are higher than when we initially closed them?
Yeah, and I'm gonna start when we ended up with the previous question. Back in the spring, when this whole thing just started, we did not know much about this virus. We did not know how it spreads. We didn't know how, is it affecting the elderly? Is it affecting the youth? We did not know much. And as time progresses and as we flatten the curve, by staying at home to buy some time and study the virus more and build up the PPE and everything else, I think we learned a little more about it. Now we're up to a point where we're trying to decide, cost analysis, cost to benefit analysis here with the kids going back to school. We've all read the research, we've all read the recommendation that kids will need to go back to school in some fashion so we can avoid a bigger problem. We learned also that the virus doesn't affect kids as bad as the adults and the older population. Although I want to caution that the kids can still contract the virus and they can still spread it. But we're working hard with the schools right now, and as of this afternoon, we included the hospital into our conversations too, because this is going to affect the whole community. As we go back to school, we want to make sure it's safe. We're working with the school boards. They're all being very, very receptive to our recommendations from public health standpoint. We want to make sure that the health system is ready for when we go back to school. I think we ought to go back to school in some fashion. Again, just a reminder, this is not a normal year, and we have to keep that in mind.
Thank you. I appreciate that answer. It's a tough question. Here's another good question. Tom from Finley asks, if I have an underlying condition, but it is well controlled by medication and or lifestyle changes, am I still at higher risk for contracting COVID-19, Bill?
It depends on what the underlying condition is. And by what I say by that is that there were a list of diseases out there that are considered that sort of thing. So let's take high blood pressure. If you have high blood pressure or high cholesterol, that's a chronic condition. But if those are well controlled, it isn't going to make any difference as far as what we can tell. If you have an underlying condition, though, that has some kind of an autoimmune problem, by that meaning like rheumatoid arthritis or that group, lupus or things like that, for a couple of reasons. One, the disease itself, and you also may be on medication that are going to cut down your ability to fight an infection. That can be a problem. And then the other group, the underlying condition, is if you've had heart problems, heart failure, not necessarily having had a heart attack, although I'd still put that in a higher risk. But anyone that's had problems with emphysema, chronic obstructive pulmonary disease, recurrent pneumonia, bronchitis is at a higher risk, and that's where the virus is going to attack. So even though it's under control and you are doing fine with medications, you are at a higher risk with those kind of diseases. So it depends on the underlying condition.
Thank you. Robert from Toledo asks, and this is another one for you, Bill, what is Blanchard Valley Health System doing to treat COVID-19 inpatients now?
Well, one of the things of the question of one is how should we treat? What do we need to treat? If you come into the hospital, that means you're sick enough to be in the hospital. And what are the parameters for that? Well, we're basically looking at what your vital signs are. So if you're running a fast pulse rate, you're breathing fast, you're running a fever, you have a cough, you have respiratory symptoms, and your oxygen level is lower than what would be expected, that's the reason that you're going to get admitted. Part of that is to observe you, to make sure that if you deteriorate very quickly, that we would have respiratory support, up even using ventilators available. Now, that would be the non-pharmacological treatments of the disease, which is where we really are. This is still a virus. There are a lot of trials out there about medications and what can be used. The one that has been shown, remdesivir, seems to be effective in really sick people. Dexamethasone 2 weeks ago came out. Dexamethasone is a steroid. It doesn't really kill or do anything to the virus, but because of the complications of what your body does, its own response, dexamethasone seems to settle things down, and the people that are severely ill or have been on respirators with both the medications seem to be effective. The question comes up about hydrochloroquine. This has been in the news again, there was I guess big video the last couple of days about hydrochloroquine. I want to say something. There was an article in the New England Journal. That's my scientific journal that all physicians would say are well respected. They did a tremendously big trial on hospitalized patients, and it didn't seem to make any difference. Now, that's a little different than what I might have talked about 6 weeks ago, where it looked like there was a higher incidence of side effects with heart disease. Everybody's on a monitor if they get put on chloroquine or hydrochloroquine, but it doesn't seem to be effective. It certainly isn't. It isn't preventing anything, and it is not curing anyone to be on that. So long answer, Scott, but we have the basic things that are there. The last one I do want to say is that we've used plasma. We talked about that before. Someone that has had COVID develops antibodies, which is a different test than whether you're sick. So your body produces, I think Karim talked about that, produces antibodies. If we take the plasma out of your blood, get rid of the red cells and the white cells, what's left? The plasma is effective because we're giving to someone else an antibody to fight that. And it is seen, and there are good studies to say it's effective. It may be in a really sick person the most effective disease we have. So I would, the other thing we have it available, but I'd encourage anyone that has had COVID that's been proven, this is again something where you can help other people by just having the ability of that being accessible. I talked to our infectious disease people today. Dr. Radnasamy said, yeah, we've been able to get it. I was really surprised. I didn't know there were that many people that donated. And I also didn't know that there were that many people that had it to be able to donate, but it's seemingly pretty effective.
That's great. I've read enough to know that it's really helps some people who are very, very, very sick. Katie from Arcadia is asking, this was for you, Karim, why is Hancock Public Health not reporting current hospitalizations?
Great question, Katie, and thank you for asking, because we do get that question a lot, and I hope that I can clarify it really quick here. One of the functions of public health in the community is to report on the disease burden on that community. How many people are hospitalized, how many people are dead, how many people are, test positive, how many people test negative, kind of keep a tab on what's going on in a particular community. And that's one of the functions we do. Now, as we started reporting on this particular disease, and we report on a whole bunch of them, monthly to the Board of Health and annually to the public in our report. That particular one is fast moving, and when we report about the numbers, we want to make sure we tally the numbers as from the start of that pandemic. Same with hospitalization. Now, we want those numbers we report on to be useful to all of you, to see how many people are still in the hospital, how many people left the hospital. Although we report on the whole number of people hospitalized connected to the COVID-19, we do also report now on how many people are still in the hospital. And we do report on confirmed numbers, which is a cumulative number, and the number of active cases, which are cases that are recent and we're dealing still with as a community.
And that would be people from Hancock County?
That is correct. And that's a great point, Scott, because we do get that question, and I'm sure you do as well.
Yeah, we do.
Yes, we all know that Blanchard Valley is a regional health system. They do serve the region around us, counties around us, but as local public health, we report only on public health on Hancock County residents.
So your numbers are going to look a little different than ours.
They're going to look a little different and probably a little less because, again, they're serving more than one county with the neighbors around us.
Great.
So our numbers pertains only to Hancock County residents.
Thank you. Another great question here. Cody from Finley asks, what is Hancock Public Health doing to enforce stricter mask wearing within local businesses? I have personally reported several businesses and nothing has been done.
Okay. Cody, I hope that when you're reporting we don't want to call it complaint, when you're reporting about a business not wearing a mask or they're not kind of closely adhering to what the governor orders and stuff like that, please, if you want to leave your phone number, I'm sure our inspectors will get back with you and give you an update on the status of that particular investigation. But what we're doing here with public health, we start to get in touch with the business, and we usually a lot of times we'll go into the business unannounced, to let them know that we got a complaint and what's going on, why we're not wearing masks, so on and so forth. Try to help the business get into compliance. Now, if we get multiple complaints and we go multiple times, that will start escalating into issuing a public health order, from public health, all the way up to reporting them to liquor control and everything else to try to get compliance. The bottom line is we want to work with businesses. We want to work closely to give them the tools to be able to comply and help protect their clients and their workforce, because it's important. If we want to keep the economy open, I think we all ought to put a mask on, social distance, wash our hands, all the good stuff that we talked about.
Yeah, I mean, from a standpoint of, again, whether it's a moral issue or what, we're trying to take care of each other. I feel bad for the businesses when people walk in and they're supposed to enforce something. Certainly, law enforcement doesn't have time to be going out and giving tickets to be doing things. And so it's not the end of the world to have to wear a mask. This is, to me, it's more of a statement of something that rather than it's really, I don't like wearing a mask either. It's irritating, it's hot, but it's like wearing a seatbelt. I mean, there's other kind of things that we try to take care of ourselves and other people. And I don't understand why there's such a problem, but it is.
The next question I had was George from Macomb, basically asking the same question. So hopefully that question's covered. But I do appreciate the question. Jen, you got anything for us?
Yes, Margaret has commented, and she was wondering if you could talk about how or will you combat the seemingly prevalent local attitude that this virus is a hoax?
Yeah, and we have a question from Todd from Rawson asked the same thing. How do you respond to people who claim it's a hoax?
Well, if I were talking to someone, is what do you mean by a hoax? If you mean, well, there isn't a COVID virus, I think usually when I hear that, it's more like you have made this a much bigger deal than what it is. Yeah, there's some people who have got infected. People get infected. The comparison has been with influenza. And so when you talk about that, it depends, I suppose, your perspective. As Karim said, we haven't seen too much here. I mean, we haven't had a lot of individuals in the hospital. But I can tell you, if you're front line and you saw this, I mean, there's been over 1,000 doctors that have died because of COVID, and those have been proven. They have all been looked at. It's not like Scott said, the death certificates, that wasn't any hoax. They died of a disease. Now, they certainly could have died of something else, but we got to go back to when we first looked at this, we didn't know what it was. Karim was exactly right. We were predicting we could have had 400 people in a hospital. We had no idea where we were going to put them. We didn't know how this was going to respond. So I think that's, I don't know what else to say, but it's certainly not a hoax from a standpoint of an infectious disease that is causing a lot of morbidity. It may have a lot more morbidity than what we think, that there's going to be individuals that don't get over this. There's been now interviews with people 6, 8, 12 weeks out, and they're still not feeling very good. And some of them are athletes, not just the elderly population. So I don't know, what's your answer to the hoax thing?
Oh, absolutely, it's not a hoax. I think that question is to the wrong crowd here. Like Dr. Coase said, you know what? We're living it. Those doctors are seeing those patients. They're seeing them suffering. They're putting them on ventilators. This is not a hoax or a joke, for that matter.
Yeah.
Our contact tracers are talking to those people day in, day out, making sure they don't have any more fever, they don't have symptoms. Those are actual individuals, actual people. When we report on 300 in our county, those are actual individuals who lives amongst us.
Thank you. Emma from Finley asks, how is BVHS doing financially during this COVID situation?
That's your Scott.
Yeah, the answer is poorly. This process has had a dramatic effect on the financial situation of the organization. And I could quote a bunch of numbers and won't, but it's been extreme. There were time periods, about a 4-week period in April, probably end of March and into April, where our revenues, when we shut down discretionary procedures, our revenues were down close to 60%. So it's been extreme. We're going to try and work our way out of it. So far, we've been able to avoid dramatic effects on people's jobs and the like. Hope we can continue to do that, but the quick answer is poorly. It's been a significant hit. Jason from Finley asks, how do you feel BVHS associates are handling the COVID-19 responsibilities? I'll let Bill take a shot at this, but I want to say I am proud as heck. I can't tell you the number of times when I've asked associates throughout the health system, are you worried about this? How you doing? My summary of what I've heard over and over and over again is, we know how to use our PPE. We've been well trained. We got this. This is what we're here for. This is why I went to medical school. This is why I went to nursing school. This is why I went to respiratory therapy school. I'm here to take care of sick people, and we're going to do that, and we're going to do it safely. So it is very rewarding to hear people say that, and I think it's borne itself out. So very proud to say I think it's been handled real well.
I completely agree with that. And it's not just been the clinical people. We got people here volunteering tonight. People have multitasked. They've taken over taking temperatures, doing different job things that we needed as we go through this. But everybody's attitude has been really good. There was super training. Someone comes into the emergency room with presumed COVID. We know how to take care of them. And things have worked out really well. I agree with Scott. I'm really proud. And as usual, when you have crises, it's everybody can or cannot step up. We had everybody step up. We've had some directors that have just done an unbelievably good job of not just here, but working in the community. We've worked with public health, and public health has worked with us. I think we've not only done a good job, but we've learned a lot.
Next question is from Kathy in Finley. And Kathy, I think we've answered this one. It has to do with hydroxychloroquine. And I'm going to, in the interest of time, hope that Dr. Kosa's comments on that answered your question. Here's another one that I kind of believe we've already dealt with, and that is there are rumors in the community about COVID cases, numbers being inflated and wrong. How can we help everyone understand that those are just rumors and the results and numbers are being documented correctly? I think Karim responded to that. My only edit to the comments is, I think early on, and I'm going back to February, March, when these deaths were happening in the hotspot cities, probably all the data isn't exactly right then, but that certainly didn't affect us, and I can tell you the data's right now. Natalie from Cary is asking us, where should employers send their employees for testing?
So I have a phone number for you on this one. This is one I want to make sure I read you. We are encouraging everyone to use Well at Work. One, they're occupational. They are set up with processes, protocols to get the testing done, to get it back to you. So that number's 419-425-5121, 55121. And this is a tough problem for businesses. Also, I think, as Karim mentioned, is individuals want to have testing done. What should they do? Sending people home, how long they quarantine. So having the Well at Work contact can be of real help in advising you what's the best thing to do for this individual person, or if you've had a quarantine problem or epidemic concern at your business.
Any comment additionally?
Just I want to add that if there's public health value for you to be tested, we'll contact the hospital, we'll contact Ohio Department of Health Lab as well to make sure you are tested. So again, our concern is the population is protected, and for surveillance, we are working on getting mass testing in town. But until then, the people who needs it for whether it's medical or for public health value, for containment, we'll push it through.
Great, thank you. Marie from Finley is asking, how will BVHS handle an influx in pediatric visits when schools return to school? When kids return to school, I think, is really what is intended in the question.
Well, I think from our standpoint, I think, Karim, you talked about that they were meeting today. The whole issue about what's going to happen when schools open is really problematic. So from our standpoint, we certainly will be able to evaluate. We'll be able to make a determination of positivity, if we have the testing, and hopefully we can get that done fairly quickly. But this is going to be a community response of how we try to figure out, with teachers being sick, with children being sick, the quarantining of them touching each other. So I don't know what you're thinking about specifically with peds, but it's going to be difficult.
It's going to be difficult, and that's why we included the hospital in our conversations with the superintendents, with the boards of education, school boards in our county, to make sure they're aware of what the plans are for when we go back to school and how we go back to school safely. We don't increase the burden on the hospital system as well.
Yeah, and I think it's important to point out that is why it's not only so good, but important for us to be working together. So from a hospital standpoint, most likely if we see a pediatric patient, it's going to be pretty quick for us. You either got it or you don't. If we just send people back into their environment, home, or to school, that's not going to really help. That's not going to be a big problem for us, but it is a big problem for the community. So we've all got to work together.
Absolutely.
And I think I'd add, and this may sound defensive, I don't really mean it to, I mean it more factually. This is unprecedented in our lifetimes. And so we're learning as we go. We're figuring things out as we go. We wish we had better answers. We live around here within the health system around a plan, do, check, act kind of model. Well, the check, act part is you make a decision, then you check and see how it's working. And if it's working great, leave it alone. If it's not, you change something and try and improve. And that's the cycle that this entire world's in, trying to figure this out. So just keep that in mind. Jen, how are we doing?
We have a couple questions.
All right.
Sarah has asked, is the process for contact tracing described earlier a national process, or does it vary state to state?
This is a national process. Again, all the criteria we get from one source, which is the Center for Disease Control and Prevention. They set up the criteria. Those criteria are not set in stone either. So those are changing as we learn more about the virus. So, as far as quarantine time, depending on the incubation of the virus, when you start your first symptoms, there's a lot of variations, and that's why we call it on a case-by-case basis. But this is a national criteria.
Great.
Susan has asked, once you have a positive result for COVID, is it recommended that another test be given in order to get a negative result to go back to work?
From my standpoint, medically, let's first start talking about testing. We were concerned when we first started about the accuracy of a test. And when that came up, there were lots of different testing availabilities. We think with our testing now that it's pretty accurate. So when you get the antigen test back that it's positive, you have it. I would say in general, because of lack of testing, I would say you don't need to have another test. We are going to look more by symptoms. One of the problems with even the testing that we have, if you repeat it and it is positive, doesn't mean you're still sick. You may still have part of the viral antigen that's in your body. So that's problematic. I don't know that we have a really good answer. Once we made the diagnosis, though, and you are over your symptoms, and I don't know what period of time you're using, we feel that people are able to go back. Now, the concern, and Karim's already brought up, how long is this going to last? Coronaviruses are colds. We all know colds. You don't have any immunity forever. And so is this going to last for 3 months, going to last for a year? We just don't know.
Yeah, if I may add real quick too, in public health and as we're doing contact tracing, we pursue one of two strategies. Either we go with the testing strategy, which is, if you're going back to work, if you're in a sensitive occupation, we recommend that you get tested. And
Right.
You need to get two negative tests before going back. Now, if we pursue another strategy, which is asymptomatic and give it time, then we'll stick with that as well. We've seen a couple cases, and those are on the increase as well, with people keep testing positive, even a month or two after they had the virus. Now we did consult with the CDC and with the hospital system, with the infectious disease doctor. Those might be fragment of the virus that you are still shedding. They're non-infectious usually. Those are just bits and pieces that some people will still chat for a long time. Some people will just test negative in a couple of weeks when they're over it. So it depends on the case.
And I think for those that are going to nursing homes, I think it's mandatory, or at least there are some rules. So we certainly on those, we are looking for a negative test.
Absolutely.
Okay, we have one more before we call it quits.
Sure. Kevin from Finley asks, do you agree with Dr. Fauci and his latest statement on wearing goggles to help protect yourself from COVID-19?
To be honest, I am not aware that he has made that. So, Karim?
I read a little bit about it this morning, and I think it's a good recommendations. We know that this is all connected. The nose, the eyes too. That's why we don't want you touching your face. Obviously, again, we're learning more, so probably we learned more that there's better protection if we wear goggles. So I'm with Dr. Fauci.
Yeah, and I would just say if that's what he said, so I'm assuming it sounds like he did. That there are some empirical evidence that would be you're reducing another chance of risk. There's all of these social distancing, respiratory etiquette, wearing a mask. Now, if you put goggles, you're going to reduce your risk. So, and it would make sense because it is part of the respiratory system.
So now in Ohio, we're going to have everybody wearing Ohio State football helmets with those plastic things in front of them now.
Good
It's
idea.
going to be great. Okay, well, with that happy thought, our fifth of these has come and gone. We certainly appreciate you tuning in. Hopefully, the time was worth yours. We always ask for feedback. The reason we've done this 5 times is people keep telling us to do these things. We'll do a 6th if it's of value. If it's not, fair enough, just let us know. So we'll sign off now. Thank you so much. And again, as we send out the survey, please give us feedback. Karim, Bill, as always, thank you so much for being with us.
Thank you. Mask on.
Mask on.